Okay, first of all, I'm very happy to be here today, so I'd like to thank the organizers for inviting me. I am a scientist, so I do research in a lab. My patients usually weigh 20 grams. They're little mice. So if you have case-specific questions, I am not a physician, I'm not an oncologist. I would recommend you to not ask them to me simply because I don't know, not because I don't want to answer your questions. So in my lab, we work on developing viruses to cure cancer. And I will be talking about this a little bit today, but I more want to do like a complete overview of different techniques exploring the immune system to cure cancer. So this little drawing here shows you how the progress in the different treatment strategies we have for the patients make the outcome better. So this graph goes from 1999 to 2012, and it shows the 5-year survival rate. And what you can see is that back in 1999, only 31% of the multiple myeloma patients were actually surviving 5 years or more after diagnosis, while in 2012, this number was up to 45%. So it's a 14% increase over 13 years, and I think this shows the power of research, because it's those new treatment strategies that provide more options for the patients. And so if a patient is not responsive to one treatment, another treatment can be tested, and this is because this treatment is available. And those treatments are developed in the labs, and you can see these numbers constantly go up. And multiple myeloma is a good example, because for some other cancers, like pancreatic cancers, those numbers are completely flat. So there hasn't been any progress for years, and there's only little things we can do. So there's lots of research happening, but there's not much progress. So this here stops in 2012. We're 6 years later now, which is a long period of time for research. And so this number is even higher now. So this is a little historical outline of myeloma treatment. So I'm not sure if it works. So in 1844, the first myeloma patient presented to the clinic. This is the first time a case was actually documented. It does not mean that it was the first patient. It simply means that it's the first time that we have a record that this patient existed and actually went for treatment. The doctors really in 1844 had absolutely no idea what was going on and what to do with this patient. And so they had to try something, and I guess the best tool they had on hand was to try giving the patient rhubarb and orange peel, which you can probably predict did not work too good. But the doctors at that time had no tools, nothing they could do, they weren't understanding. And really, if you look at this little scale here, you can see that it's only 50 years later, in 1895, that the plasma cells were identified. And this is huge, because if you don't understand what the disease is, what causes the disease, you cannot treat it. And so 50 years before those cells were identified, it was absolutely impossible to have a good guess at how to treat those patients. And then it took another 50 years before these are literally chemicals, were tried to actually treat those patients, work more or less. And here I squared in red the different options that, even if they didn't know it was doing it, exploit the patient's immune system to be efficient. And so you can see that from 2013, 2015, and now we're even 3 years later, there was more and more strategies exploiting the immune system to treat cancer in myeloma patients. And those are the strategies I want to talk about today, but mostly the really new ones, so the ones maybe you don't know about yet. So the concept behind cancer immunotherapy is the same one as behind vaccination. So the idea of vaccination is to train your own body to fight the danger. And so this danger can be under different forms. So it could be a virus infection, it could be a bacteria, it could also be cancer. So cancer is not normal. Your immune system can tell the difference between a cancer and a normal organ. And this is very powerful because your immune system is in your blood, and your blood patrols your whole body. There's no site of your body that your blood cannot access. And so this is a huge advantage for a disease where you have lots of metastases, a disease where the cancer is not only local, but it's spread through the body because your immune system can access all of those different sites. So if you can teach your immune system to eliminate cancer, it can do it everywhere, which is a huge advantage. Also, what's nice is the long-term protection. So this is something we call immune memory. For the same reason that children which are vaccinated at very young age can still 60 years later fight the disease against which they're vaccinated, if we can teach your immune system to fight your cancer, it could also fight a relapse. So it could prevent a relapse from happening. And this is why we're really trying to teach the immune system to fight its own threats. And here on the left, you have a little cartoon. Simply illustrates what I just said. So you have the immune cells in beige, orange, and yellow. And you have here the flu virus in blue. And so even if the flu virus tries to deny that it's a virus, it has absolutely no chance because the immune cells were previously warned. And this is exactly what vaccination is. So the immune system is pretty much presented with a virus in this case and told if ever this virus shows up, eliminate it, it's a threat, it will make you sick. And so by doing that, the immune cells are ready. And so they can control this infection before it can even develop. So in some cases, the side effects will be to have absolutely nothing. So you will not even have fever, like there will be nothing caused by the infection. And in other cases, the side effects will simply be way lower. So a little fever, the infection will be cleared faster. But this is really the power of your immune cells. So this is what we're trying to do with cancer immunotherapy. So this here is a little complicated, but all I want you to look at is on top here you have the name of different cancer types, and on the left axis here you have numbers that are smaller on the bottom and higher on the top. And what this shows is how different the different cancers look to your body. So as I said, a cancer is not a normal organ. Most of the time they look different because they accumulated lots of mutations. And so those mutations allow your immune system to tell that they're not normal. On the right here, you have all of the highest numbers compared to the ones on the left. And you can see that those are all the cancers that look extremely different to your body. And so what kind of cancers do we have here? We have melanoma, which is skin cancer, caused mostly by UV light, so by the sun. We have some lung cancer, which not in all cases, but in lots of cases can be caused by cigarette. We have others, I'm not going to go through, but you probably know that liver cancer can sometimes be caused by alcohol. And so a common factor here is that those cancers are often caused by environmental factors. And so those factors cause mutations. UV lights cause mutation, cigarette cause mutation. And so these cancers here are very mutated. And because of that, the immune system can easily recognize them. On the left side here, you have the cancers that don't have many mutations. One thing, not for all of them, but some of them affect children, like acute leukemia, for example. And the reason for that is that mutations also accumulate during life. So children had less time to accumulate mutation, and so their cancers don't look as different as for other cancers. And pretty much exactly in the middle, you have myeloma, which is a good thing, because it means that myeloma looks different to your body than normal cells, but it's not as different as other cancers. So it needs a little help. We have to teach the immune system to recognize myeloma if we want immunotherapy to be efficient. I'm saying they look different, and you can see it for yourself now. So on the left, you have a picture of normal bone marrow, so took from a healthy individual or a patient that did not have myeloma, sorry. And on the right here, you have bone marrow from a multiple myeloma patient. And you can see here, I put little arrows, those very big blue cells. You can see they're very big compared to the same ones that you have on the other picture. And you can see also that there's lots of them. So lots and lots of this bone marrow is actually consisting of those cells, and this is what myeloma is. This is what it looks like. And if your eye can tell the difference, your immune system certainly can. Your immune system is composed of different cells. So in your blood, you have the liquid is plasma. And then you have the red blood cells and the white blood cells. The white blood cells are your immune cells. And there's lots of them, so I don't want you to remember those names here. I just want you to focus on the T cells. So the T cells are your soldiers. Other cells can also control cancer, but T cells are especially good at it. And most of the strategies I'm going to talk about today are actually strategies that exploit the power of the T cells. So these are the important white blood cells you have to focus on today. This is what we're trying to achieve. So this is not an actual picture, it's a drawing, probably from a kid somewhere. And here you can tell that the ninja cell is your T cell. And this is what we're trying to do. So we want those cells to be angry, we want them to attack cancer, and we want them to kill cancer. This is an actual picture. And so you can see in yellow you have a cancer cell. And in pink, in this case, you have 4 different T cells. And so what happens when those cells interact together is that the T cell starts producing and secreting things. 2 things mostly. One of them is called perforin. And as the name suggests, perforin will perforate the cell. So it will create little holes in the membrane of the cancer cell. And then the T cell would start secreting poison. And that poison is called granzyme. And when granzyme will enter the cell through those holes created by perforin, the cancer cell will die. So as long as we can take this T cell very close to this cancer cell will die. So this is what we're trying to do. And today I want to focus mostly on 4 different ways to make cancer immunotherapy better and 4 strategies that we can exploit so those immune cells will kill those cancer cells. So the first here I'm going to talk about is to use what would be the equivalent of T cell fertilizer. So we want to take those soldiers that we have and we want to make more and more of that. So I'm going to talk about this. Another strategy we have here is to outsmart cancer. So cancer is smart. Cancer does not want to be eliminated by the immune system. And in order to be there, it had to evolve strategies to avoid dissemination. So we're going to talk about this. We can also give the T cells more power. So we want to make them super soldier. We want to give them the power of kill more. And we want to make the power of kill different ones and to remember and things like that. So we're going to talk about this. And my favorite personal one, because I work on this, is to make this cancer visible to the immune system. So I'm going to go over this today. So picture here on the left that these are cells we just took from your blood. So you can see that in this case, let's just pretend they're all T cells. You can see that those cells have different colors. And so this is because, as I said, you have immune memory. So your immune system remembers all the disease you saw through your life. So here, for example, you would have a red cell recognizing measles virus because you're vaccinated against it. Here you would have one against the flu because you got it once. And here in green, you would have T cells that could potentially recognize cancer. But there's not lots of them. There's just a couple of them. So what we'd like to do is identify them and make more and more and more and more of them. So then there's more soldiers to attack the disease. And this is what we call adoptive cell therapy. So you have a little cartoon here. So you have a patient with a tumor. From a biopsy, you can see that there's not only tumor cell in the biopsy. There's going to be tumor cells, in this case in pale pink, but there are also going to be immune cells. So in this case, let's pretend they're all T cells in dark pink and orange. So you can see that from a sample that we take from a biopsy, we can isolate different types of cells. And so we can purify them, we can get rid of all the cancer cells, we can do all of that in the lab. And then in this case, for example, we tested those cells and realized that the dark pink ones were the good ones. They're the ones that will kill cancer. Okay, so we get rid of the orange ones. We make more and more of the dark pink ones. When I say more, I'm talking about millions and millions of cells, not only 6 like in this picture. And then we're going to change them if we have to make them even better and give them back to the patients. And so when those cells are now in the blood, they're going to go everywhere in the body, and they're going to look for the disease. And if they see the disease, they can potentially kill it. Adoptive cell therapy works very well. But in some cases, it needs a little more help. So as I said, the cancer is very clever. It will have ways sometimes to avoid these T cells from killing them. So there are different things we can do. For example, we can use what we call BITES. So BITES is an acronym. It means bispecific T cell engagers. It doesn't really matter what it means. What matters really is what they do. So in this case here, you have a cancer cell and you have a T cell. And so the BITE is what you have in blue here in the middle. And so the T cell would like to fight this cancer cell, but it cannot find it. It is not close to the cancer cell. But when we use the BITES, which are like blue here, it creates a bridge between the cancer cell and the T cell. And the simple fact of having them in close proximity will allow this T cell to then kill this cancer cell. So again, this is not a picture. This here is more like a computer modelization of what would be happening. You don't have to read all of this. Pretty much the only thing I want to show here is on the right here, sorry, you have a BITE. So you can see that the BITE here links on one side, this is the T cell, on the other side you have the cancer cell, brings them together, and then you have the T cell releasing those things I was talking about before. So here you have the perforin creating those little holes, and you have the granzyme that can then enter the cancer cell, and these things pretty much just cause the cancer cell to die. So this is what we're trying to do. There's one that is currently approved for the treatment of myeloma. It was on the previous slide. This is the name here. Those things are very difficult to pronounce for us too, so I can try. Blinatumomab, probably sounds about right. So this is one that is currently approved for myeloma treatment. There are more and more that are being tested. I looked it up. I think there's something around 12 clinical trials currently going on with BITES. And so this is something that is coming, and it is working very well, especially for blood cancers. So this one is a little more complicated, but this one completely revolutionized cancer treatment. It's called immune checkpoint inhibitors. Also called immune checkpoint blockade. Maybe you know the commercial names more. We're talking about ipilimumab, pembrolizumab, nivolumab. Maybe you've heard about that. So how this works is that it releases the brake on the immune response. So when I was talking about outsmarting cancer earlier, this is what I mean. So on the left picture here, you have a T cell in orange that is recognizing a tumor cell. It doesn't really matter what those things are, but this is how the T cell recognizes a tumor cell. And so because those cells are interacting together and they're very close and they're talking to each other, technically this T cell could kill this tumor cell. But as I said, the cancer is clever. So the tumor cell at its surface upregulates what we call inhibitory ligands. And the T cell has what we call inhibitory receptors. And when this inhibitory receptor interacts with this inhibitory ligand, the T cell loses all possibility of killing this tumor cell. This could seem like something that is not useful, but it's actually extremely important to prevent things like autoimmunity, like arthritis, diabetes. If you don't have these inhibitory interactions, you will have the immune system attacking your own body. So you don't want that. Those are very important things. It's simply that the tumor is exploiting this to its advantage. So what we do is that we actually give what we call immune checkpoint inhibitors. And so those are drugs that we give to the patient, and they actually bind to either the receptor or the ligand. And the result of this is that the receptor and the ligand cannot interact together anymore. And so this T cell is now completely free to kill this tumor cell. So it releases the function of the T cells. The tumor cell cannot tell this T cell anymore to not kill it. It just dies. So these work very good, especially for the first indication that they approved it was for melanoma. And it really, really progressed rapidly. So this is just to show you how difficult and long it sometimes is from the discovery in the lab to the time where it's actually approved for the use in patient. So I talked about immune checkpoint inhibitor. One of them is called CTLA4. It's simply the name we give this receptor. And so in 1985, the year I was born, CTLA4 was identified. And so lots of research happened. Nearly 15 years later, it was recognized that there could be some clinical use to this. So first it was identified as something new, very exciting, nobody knew about, but we didn't know exactly how to control it, what we could do with it. I say we, but really I was still a child, so they didn't know. And then 15 years later, they recognized, oh, maybe we could do some drug, create something, and treat patients with this. So, okay, they talked about it a lot. They talked about it for 6-7 years. Then phase 1, phase 2, phase 3 trial finally approved 2011. So this is very long, I understand, but it's also, this was the first one. So it went from we know nothing about this, we don't know if it would be dangerous, we have no idea how to exploit this pathway, to we finally have a clinical product that we can give patients. And it was actually approved in multiple countries. So sometimes you have approval somewhere in China, things that will never ever be approved here just because it's not the same criteria. But here in 2011 it was approved in the States and then different places. And so things are now progressing fast. So this was the first one, it was CTLA4, it's the one that's called ipilimumab. But after that, there was lots with other immune checkpoint, PD-1, PD-L1, and now there's more and more and more, and lots of them are actually already approved. And when I say that it revolutionized cancer treatment, I'm just showing a graph here, so some of you might be familiar with those. This is a survival analysis, so pretty much on the left axis, you have the survival probability. So all of the patients are on this axis. If you have a number of 1, it means that all of the patients are alive. And here we're talking about stage 4 unresectable melanoma, something that pretty much had no treatment a couple of years ago. And if you look at the gray curve, you can see that it goes down very rapidly. On the bottom, you have weeks. And so 250 would be 5 years. And you can see that roughly 30% of the patients were still alive after 5 years, while if they were given, in this case it's actually nivolumab, if they were given nivolumab only, this number went up to over 60%. So this is huge because there was not many options for these patients, and these immune checkpoints are so far giving great results in most cancers. My personal favorite, the little bugs. So viruses come in all forms and colors and shapes. And in this slide here, you have actually only two that are actual pictures. So this is what vaccinia virus looks like. This is what VSV looks like. The other ones are computer modelization of what the virus should look like. So they were resembled on different microscopy images we had. And so for the same reason that viruses come in different shapes and colors, viruses like to infect different organisms. So you may have heard of the swine flu or the avian flu. So the swine flu preferentially infects pigs, and the avian flu preferentially infects birds. And so for the same reason, you have some virus that will rather infect humans or infect insects in some instances. Same concept goes to organs. So the hepatitis C virus likes to infect the liver, for example. Some other viruses like to infect the skin. Well, interestingly, some viruses like to infect cancer. So we decided to exploit this. What if we can select those viruses that infect cancer, give them to the patients, and then the virus will do their work without us having to do anything else? So those viruses that preferentially infect and kill cancer are called oncolytic viruses. Either they're found in the nature, and we try them and we realize, we do that in the lab, not in people. We realize that those viruses actually like to kill cancer. Or in the lab, because the technology is very progressed by now, we can actually create whichever virus we want. So viruses, like human, have genetic information, and this is contained in DNA or RNA, depending on the virus. And so we can go and change this sequence as we wish and create a virus that behaves differently. So we can take a virus that would be dangerous and make it not dangerous. We can take a virus that would infect the liver and make it infect cancer instead. And so those are called oncolytic viruses. And how do they work? The concept is pretty simple. So you have a virus here in blue, it's an oncolytic virus, cancer cell in brown. And so this virus first has to enter the cell in order to kill it. Then the virus will replicate, produce more and more copies of itself to the point that the cell won't be able to take it and will explode. And when the cell explodes, it actually releases thousands and thousands of new viruses that can then infect other cancer cells and replicate and produce new viruses. So it self-amplifies. And it is nice because it's cancer specific. So here we're talking of side effects like chills, fever, headaches, muscle pain. So symptoms that look like the flu symptoms for 24 to 48 hours, which makes sense because it's a virus. And after that time, your immune system is able to completely clear this virus because that's what your immune system does. On the bottom here, I've put 2 different clinical trial numbers. I'm also going to show a picture in 2-3 slides of an actual response from a patient to oncolytic viral therapy. I believe one of those is reovirus, the other one is VSV. Doesn't really matter which virus it is. It's more to say that there's lots of different viruses that are being tested in lots of different cancer types. This is one of the ways by which the virus acts. Another thing that it does is that it will destroy specifically the cancer blood vessel. And so the cancer will not get any nutrients from the blood vessels. This is not good for a cancer's growth, so the cancer cannot grow if it's not getting blood and energy. This is a second way. A third way is the one that interests us most today, is that by being in the cancer, the virus attracts the attention of the immune system. So even if the cancer is good at hiding from the immune system is perfectly trained at recognizing viruses. So the simple fact that some viruses are in that cancer, in those cancer cells, it will attract the attention of those immune cells, which will be able to tell not only, oh, there's a virus here, we should clear it, but also, oh, this cell looks weird. Maybe we should remember what it looks like. So if ever we see other cells like this, we should kill them. And so this is an actual myeloma patient, had a lesion on the forehead. So this is the same 2 different ways of seeing it. Here you can see a clear bump on the forehead. This is a cross section, so it's true imaging. It was not actually cut in. It's just an image that shows you that the cancer was clearly there. This patient was treated directly in the blood with the measles virus, an oncolytic measles virus, which is very safe. And so you can see that without even the need for surgery, this cancer is completely gone. This was a couple of weeks after treatment. We're 5 years later today, and this patient is still alive. And this lady comes to all of our oncolytic virus meetings to tell us her story, and we like to hear about it a lot because it's for results like this that we do research. So another option I want to talk about, I believe there was somebody, I don't know if there's somebody still after me talking about CAR T cells, but maybe you've heard about CAR T cells. They're in the news a lot. I'm just going to talk about it a bit here. So as I said, the T cells are your fighters. So you want those soldiers to be there. How CAR T cells work is that we take pretty much any T cell you have, even if it's meant to recognize the flu. It's not meant for cancer. We take it and we change it. And we put at its surface what we called chimeric antigen receptor, which is CARs. And so those red CARs here will redirect the activity of this T cell toward cancer cells. So whatever this T cell was meant to do, its new function is to kill cancer. And how do those CARs work? Well, I told you earlier about how your immune system could tell the difference between a cancer cell and a normal cell. Well, we make sure that those CARs will actually go and bind those cancer cells. And this is how the treatment happens. So blood is collected, and from this blood, the T cells are isolated. A little like earlier with adoptive cell therapy, but here we're talking about blood and not about the biopsy. And so it doesn't really matter how we do it, but we add CARs to those cells. So here in red, we have the CARs at the surface of those T cells. And then we expand them, we generate more and more, and billions of those cells. Then there's some quality control happening. This is produced in extremely sterile conditions, very well controlled. We want to make sure that it's not dangerous, so lots of tests are done. And then those cells are given back to the patients, and once again, they can patrol the whole body through the bloodstream, and then they can find and kill the cancer. So this is the concept of CAR T cells. They work extremely good for blood cancer. They're already approved for some leukemia. They don't work too good for solid cancer so far, so things like colon cancer, breast cancer, pancreatic cancer. So there's still work to do for that, but myeloma is a blood cancer, and so this is a very, very promising option. This is an actual patient. On the left, you have a picture. You have all of the cancer lesions in the black here. Some of this black is actually normal, so the brain should be black, the bladder, as well as the kidneys here, but all the rest is cancer. And you can see that after CAR T-cell treatment, those are entirely gone. So here we're talking about a patient that experienced complete cure. This is one example. It is not all the patients that react this good, but like there's more and more research being done because the objective would be to achieve this kind of response in all patients. So to conclude, I've talked about those 4 options today. So earlier when I was talking about T-cell fertilizer, I was talking about the technique of adoptive cell transfer. So find those soldiers, expand them, give them back, so now there's a whole army fighting this cancer. When I was talking about outsmarting cancer, I was talking about things like immune checkpoint inhibitors. So even if the cancer is smart and finds ways to hide from the immune system, we're taking those ways away. We don't want this cancer cell to survive. Then when I talk about making it super soldiers, we could do things with CAR T cells, completely redirecting their energy towards the cancer, or we can use bites where we actually bring the cancer cells directly, bring the tumor cells directly at the cancer so they can interact and fight each other. And I also talked about oncolytic viruses, which make the cancer visible to the immune system, just because the immune system is very well trained at recognizing these viruses. So in conclusion, there are new treatment options being developed every day, and this is true. If you go to some cancer conferences, it's very overwhelming, even trying to keep up with everything that's being developed. Lots of things are very promising. This is very true for myeloma. We're talking about CARs, we're talking about bites, we're talking about oncolytic viruses. You know, some of those things are already approved for the treatment, so it's progressing very fast. Some myeloma patients have experienced complete cures with CAR T cells. This is also the case of oncolytic viral therapy. And so I think there's real hope for this one specific cancer. And I would like to point out this website here, www.clinicaltrials.com. You might know this website already. So you can pretty much type the disease you're interested in and the treatment you're interested in. So some of the trials I listed today I found on this website. It's updated very regularly. You can see around the world what's happening, which cancers, with which indication. Here I just typed cancer, immunotherapy, and oncolytic virus, but if you're interested in CARs, you can type CARs. Myeloma, multiple myeloma, you can type different things. And I think this is very, very useful. You can also see if they're still enrolling patient and how to join this trial and things like that. Sadly, lots and lots of those are actually in the States. They don't refuse Canadian patients, but I think everybody's conscious of the cost of being treated in the States. However, there are some trials in Canada, and there's more and more of those. We now have organizations like Biocan Research, for example, who supports really the discoveries we make in the lab. They support us to bring them to the clinic, so there's actually more and more trials happening in Canada these days. So with this, I'll be taking questions.